Hi, everyone. Welcome back to the ISTH Pulse Podcast. Today, we're talking about the evolving role of mechanical thrombectomy in the management of patients who have venous thromboembolism, or VTE. Now, we all know that anticoagulation is the foundation of care for patients who have either a deep vein thrombosis or a pulmonary embolism. But advances in catheter-based therapies are expanding the treatment options for these patients who may need something more than just a medication alone. So in today's discussion, we're going to explore this topic a little further. And this has been brought to you by Inari, which is now part of the Stryker Corporation. So to join us for the discussion, we have two distinguished experts, Dr. Victor Tapson, who's a pulmonologist and has really been a thought leader in this field, along with Dr. Andrew Niekamp, who's an interventional radiologist really on the front lines of device-based therapies. And together, we're going to discuss how mechanical thrombectomy is shaping the standard of care, what the ideal patient might look like, and what the future is going to hold for this very innovative and exciting approach. Dr. Tapson, Dr. Niekamp, thanks so much for joining us on the podcast.
Great to be here, Geoff. Good to see you.
Hi, everyone. Happy to be here.
So for all of the audience members, I want to introduce our two guests briefly. Dr. Vic Tapson is professor of medicine at Cedars-Sinai Medical Center in Los Angeles, where he actually started their VTE program back in 2014. He then served as the first elected president of the U.S. PERT Consortium and currently serves as a senior director of medical affairs at Inari. He's internationally recognized for his expertise in PE, a career really he's dedicated towards advancing patient care, research, and education in thrombosis and pulmonary vascular disease. Dr. Niekamp is an interventional radiologist also based in the United States and serves as senior director of medical affairs at Inari. He specializes in minimally invasive, image-guided therapies and really has a focus on endovascular treatment for both deep vein thrombosis, DVT, and pulmonary embolism, PE. He's been at the forefront of integrating mechanical thrombectomy into routine practice, thinking about how we combine technical expertise with patient-centered approaches so that we can improve outcomes. And so you two are really the perfect people to help us have this conversation and think about how mechanical thrombectomy is transforming care for VTE patients. So to start out, I'm going to maybe ask us to just look at the current landscape of DVT and PE care. And Vic, perhaps I'll start with you. As you think about this broadly, what does care look like for our patients who have, venous thromboembolism, whether it's in their legs or their lungs? And what are some of the challenges that you hear from clinicians that they face every single day?
Well, Geoff, it's a great question. And as you well know, we've come a long way with VTE over the past couple of decades. We had trouble even with prophylaxis 30 years ago. Now, I think we do a great job with that. We've got new anticoagulants, DOACs, oral anticoagulants, and as you said, anticoagulants really help move this disease state forward over the decades. My concern is that cases are still being missed. Patients are still dying from this disease, sometimes even before they're diagnosed. I think we need to do a better job with it, Geoff. There's studies suggesting the death rate from VTE may actually be going up. The numbers may be getting worse. One study from Chicago from 2020 suggests just that. A study from 2023 by the CDC suggests the death rate from high-risk PE may be going up. Another study suggests the death rate in cancer patients from VTE may be going up. So the studies are hard to interpret, Geoff, but I think they're telling us we're not doing a good enough job. We're trying, we need more research. And I think this new area of mechanical thrombectomy may be one area that we can perhaps improve on. So we've made a lot of progress. I think we have work still to do.
I hear often people say, well, the reason you're seeing more PE, for instance, is that we've got these better scanners and we're scanning everyone. So you're just picking up the little ones. But, in my clinical practice, I feel like that could be true, but we also have more complex patients that are living longer with more comorbidities, many of which are prothrombotic. And we may be seeing more complicated versions of pulmonary embolism, which really require a full armamentarium of treatment strategies. Does that resonate for you in your practice as well?
Absolutely, Geoff. And I think, again, we don't know the reason for an increase in death rate, or even if, in fact, it is really going up. I think the idea is clearly we all see these patients still dying. We still see patients crashing on the floor. We still see patients coming in the ED that don't make it after their cardiac arrest. So I think we have to do a better job. But I think some of these studies are not perfect, and we need more explaining. But let's move ahead and try to diagnose more and try to treat better.
Well, in that vein, Andrew, maybe I'll turn to you. You know, for a lot of clinicians who don't think about this all the time, they know we have anticoagulation as a therapy. They've probably heard of systemic thrombolysis as something that's been around for, a couple decades. And then they sort of think of these catheter-based therapies. And I'm wondering if you could give us a little bit of a primer on what does it mean when we say mechanical thrombectomy? What are you talking about, and how is that different than some of the other therapies that people are hearing about or perhaps even using?
Yeah, and that's a really good question. I think the basis of understanding exactly what is going on, a lot of things in medicine turn out to be esoteric, and people just kind of don't really dive in and understand the actually what's going on, and it's hard to, right? You've got so much other things going on within your own respective specialties. It's hard to keep up with everything else that's going on. So the basis of what really makes mechanical thrombectomy different, right, is the physical removal of the thrombus or the emboli from the body. And what really the hypothesis behind the entire um, paradigm of the treatment is that by removing this thrombus and actually extirpating it from the body, you're able to not only make short-term but long-term benefits for the
Mm.
patients, right? I think especially when, even when I was training, before most of these devices started to come onto the scene, it was the old school. If you were going to do an intervention in, say, a DVT or even a PE, and Vic, I'm sure you probably heard this from interventionalists when you were working with them, create a channel, anticoagulation will take care of the rest, right?
Mm.
That was really the whole thought process behind everything. And I also think really one really important thing to discuss here is this is never going to be thrombectomy versus anticoagulation, right? Thrombectomy is not possible without anticoagulation. That is always going to be a key cornerstone of therapy. It's, can we help the anticoagulation do a better job for these patients long term, and can we do something more upfront to prevent long-term outcomes and short-term mortality outcomes, right? So by the physical removal, and hopefully by that, we want 100% clot removal. I think especially in the DVT space, we're seeing more and more evidence that 100% clot removal, wall-to-wall clot clearance leads to better outcomes for these patients. In the PE space, we think it's probably going to be the same, but that's why we're conducting multiple randomized control trials now to figure out, as far as clot burden goes, how much getting out of the lungs really does improve these patients. But that's really the whole goal behind this, right? Is full removal of clot, opening up the pipes, right? At the end of the day, it's just plumbing, and we need to make sure that we can get everything out of there and make sure that these patients can get back to the normal life that they had before, which should really be our goal, right?
Well, I know it's more than just plumbing because the folks who do this are really technically quite skilled, and I know you're one of them. But the basics is that you're passing a catheter through the vein, and it's either into one of the deep veins of the leg or into one of the pulmonary arteries. And then you're using some sort of a device that either sucks out or removes the clot through the catheter. Is that kind of the basic understanding?
Yeah, that's exactly right. So there's a lot of different devices that are coming on to the market now, all with a little bit of a different, but the main goal, yes, the two bit large buckets you can kind of group them in are going to be an aspiration based, whether that be a syringe based, pump based, some sort of other electrical equipment based aspiration removal of thrombus. And then they're going to be what I would say is probably the more mechanical, which is actually like physical removal, which would be something with a basket or a coring element that actually physically removes the thrombus and extirpates it out of the body without an aspiration device or anything like that. And that's a little bit more, that's going to be a little bit more of a bloodless ability, because you don't have to worry about, obviously aspirating out any blood with it. But those are two of the main buckets, would be an aspiration-based therapy and then more of a mechanical-based therapy, physically removing the clot out through a nitinol coring element.
That's really helpful. You know, as I think about both of those two buckets you just described as mechanical thrombectomy, could you help to contrast that just a little bit with catheter-based thrombolysis, something that other people may have heard of? They may have seen some other trials in that space. What are the differences between those two?
Yeah, absolutely. So that's a great question. So what kind of launched the whole intervention into catheter-based therapy was the lytic catheters, right? Whether that be ultrasound-assisted lytic catheters, reolytic
Mm.
catheters, or just the straight side hole catheters that would drip TPA. So the catheter-based infusions and the TPA-based therapies, basically, that's just where you have a small catheter that goes through the clot, multiple different side holes so that you're actually able to instill the TPA throughout the length of the entire thrombus. Some of these devices have ultrasound embedded within them that help agitate up the clot. Some of them actually have a rheolytic aspiration therapy, which also helps kind of extirpate and move around the TPA and make it more instilled. And some of them are very simple side hole catheters, Craig McNamara's Unifuse, standard stuff that have been used in the arterial space, and those just drip overnight. And so that's requiring more on the pharmacomechanical dissolution of clot, right? It's not so much the actual physical removal of clot. It's really relying on the dissolution of the clot in those therapies.
So Vic, I'll maybe turn back to you. As Andrew just described, it seems like one of the differences, although certainly not the only one, is the time that it takes to do these procedures. And are you leaving something in for hours while you're dripping a medicine, or are you really removing the clot in a quicker way? Are there other things about mechanical thrombectomy that you see as really being a significant development in how we think about managing patients with acute DVT or acute PE?
Well, sure, Joe. I think the speed that it can be done is just incredible. I mean, it might be a little faster for an interventionalist to place an infusion catheter for lytics, but overall, the patient has to go to the ICU.
Mm.
The patient's got to lay there with catheters in them, and it takes longer to get benefit. We worry about the risk of bleeding with thrombolysis. It may be lower with lower doses than it is with systemic lytics. Still a concern. You know, we learned about catheter embolectomy in 1969 from Laser Greenfield. His first two cases he published in 1971, remember?
I
And
do.
interesting to me, Jeff, 30 years later in 1993, he published 46 more cases. The
Yeah.
mortality after that, catheter embolectomy, 30% in 1993. Mortality in Mitch Silver's meta-analysis from 2023, 30%. 30 years
Mhm.
later, same mortality. So again, now what I see, as Andy explained, is we've seen a really advance in the technical aspects. Laser's technique was a little more crude. I mean, amazing that he came up with this idea, but now we're on later generations of catheter embolectomy, and so I think the device has improved so much more now that we're really seeing some potential differences.
As you think about those advances and these, new techniques that we have, how do we pick an appropriate patient to undergo mechanical thrombectomy? Maybe Vic, I'll start with you as a pulmonologist. You evaluate a lot of patients. What kinds of patients do you see that you say, gosh, this is somebody for whom we should be thinking about a mechanical thrombectomy approach?
Great question, Jeff. And that question, I think, is really the holy grail here. And I'd love to hear Andy's thoughts about this too. I would say when you diagnose someone, you see a CT, I first look at the CT scan, look at the clot. If it's more proximal clot, when I say more
Mm.
proximal, to me at least lobar, maybe not necessarily main PA, but at least lobar. So I like to see the appearance of it. We like to see some degree of right ventricular abnormality. RV-LV ratio greater than 1, certainly greater than 1.5. We've seen mortality differences. And then vital signs to me are critical. If I look at a CT scan, look at the vital signs, someone's heart rate's 120, I'm concerned.
Yeah.
Especially if they've been on heparin already for 3 or 4 hours or 6 hours, they're no better, no slower. Lucas Hobom did a nice paper a few years back finding that heart rate greater than 100 predicts mortality in QPE, fourfold increase in death rate. Heart doesn't mean that everyone with a heart rate of 101 needs to undergo a procedure, but it makes you stop to think. Vital signs, soft blood pressure between 90 and 100 would be concerning, even though that's not really massive PE. Appearance, Jeff, I'm from that era where we did physical exams. I know you guys do too. But I mean, looking at someone's appearance, are they tripoding? Are they short of breath? Are they breathing quickly? Hypoxemia. Is there significant hypoxemia? And if we can't tell, if we're not agreeing, and sometimes the team might not agree on when to move ahead, consider a short walk. Maybe not a 6-minute walk, but maybe a short walk. across the ward. What's the heart rate do? What's the SAT do? What are the patient's symptoms? Sometimes those help us make decisions. So that would be an intermediate risk type patient we might want to consider intervening on. Certainly, I would insist on at least discussing that case carefully.
I think you laid out a lot of features about those acute PE cases that make me nervous when I'm seeing them. And you're absolutely right. The eyeball test is probably the one that often sways me the most, but those vital signs are critical in knowing the trend. Andy, I'm wondering if you could maybe help us think about this from a DVT standpoint. When do you think about mechanical thrombectomy in a DVT patient? And are there any other features as a proceduralist you're thinking about that maybe some of the clinicians who don't do procedures don't always consider?
Yeah, that's a fantastic question. And as opposed to the PE space, I think we actually have a little bit better data that points us to how we should be looking at some of these DVT patients, right? So we all know the ATTRACT trial, the landmark trial, but when you actually do the sub-analysis of patients that did have iliofemoral DVT, those that were treated, that were intervened upon, which it also is important to remember at that time was either lytics or angiojet, which is rheolytic, lysis versus anticoagulation. Mechanical wasn't really included in that study, but even those patients that underwent an intervention had a decreased severity of PTS compared to those that got anticoagulation alone. So for my personal practice, I mean, the first thing I'm going to do is look at phlegmasia. If they have phlegmasia, absolutely, we need to get the clot out immediately, right? We need to restore patency. That patient's at risk of limb loss. I think that's pretty much universally agreed upon across medicine. But when we start getting into actual DVT, right? If it's an iliofemoral DVT, we're seeing more and more data, CAVA, CAVENT, ATTRACT, all showing that iliofemoral DVT, we should really be intervening on these patients. We have an opportunity to really decrease their severity of PTS. And I have to say, as somebody who went through medical school learning about PTS, I thought this was my legs a little swollen at the end of the day. I have to wear some compression stockings. And it was not until I got into clinical practice and actually started taking care of these patients. I mean, tears in the office, lifestyle, just debilitating lifestyle changes from this disease state. It is horrendous. These patients are really, really, I mean, the mental toll that it takes, it's a really horrible disease. So the ability to be able to reduce that and give these patients back a normal lifestyle is paramount. And so I think anybody that comes into my practice with an iliofemoral DVT, they're going to get treated. And another funny thing that I hear is it symptomatic or not? Well, they came to the ED, so if anything's making them come into the hospital, I'm pretty sure it's symptomatic or not. Now, FemPop, I think we're still up in the air. Personally, I don't treat FemPop off the bat unless it's a phlegmatic patient. However, I do follow those patients up. If their Volta scores start to increase and they start showing signs of PTS and they're not improving on anticoagulation, I have a real talk with them and I will offer them treatment down the line. And that's another benefit of mechanical thrombectomy. It doesn't limit our therapy to the first 14 days. We're now able to extend that treatment window to longer than that and be able to treat them down the line if need be.
Are there any patients that you can think of where you've used a mechanical thrombectomy approach and it's really been meaningful, either a PE or a DVT patient, maybe an illustrative case?
Oh, I could probably take up the rest of the time with those actually. I actually did not enjoy treating PE. I just did not really know if we were making a big impact. And it wasn't until I kind of got my hands on the mechanical devices that was the first time on table I had patients tell me that they felt better. Literally saying, I can breathe again. They feel back to themselves. I get them up and walk them the next day and they go home the very next day. Then following them up, I had a PE, so patients think they've had a PE, so they should have some sort of residual from it. That shouldn't be the goal. The goal should be to be back to a normal life, right? And so when I followed these patients up months, 6 months, a year later, seeing that they were living a completely normal life, normal 6-minute walk test, normal quality of life scores, that was really moving to me and really helped me know that not only are we doing something short term, but we're definitely doing something long term. Same in the DVT aspect. And that's another thing about VTE patients is this disease does not discriminate, right? These are not going to be your elderly patients where you're hoping to help them limp on for a few more months. These affect 20-year-olds, 30-year-olds, 40-year-olds, 50-year-olds. There's no discrimination here. So being able to help so many people and get them back to a normal life. And for me, it's seeing the parents go back and being able to be parents with their kids. That really those stories always really resonate with me, and that happens quite frequently in VTE patients.
Well, I think a lot of us have heard similar stories that are really impactful, and we realize how much patients appreciate feeling better when we are able to do things. Vic, maybe I'll turn to you for this last question. You know, we're also scientists, and we really like to have the data that helps us understand when to use different therapies. Could you tell us a little bit about what's going on right now from a trial standpoint, a generating data standpoint, and how do you see mechanical thrombectomy maybe playing a role in the future, depending on how some of these trials play out?
Well, I think we're going to see a bigger role, Geoff. I really do. As Andy mentioned, there's a number of devices coming out. So competition sometimes is a good thing to keep everybody on their toes. We're seeing a lot of improvement in existing devices and studies, as you mentioned. Right now, ongoing studies include Peerless 2, which is a 1,200 patient study comparing mechanical thrombectomy with anticoagulation alone. We have the PE track study looking at multiple devices, including mechanical thrombectomy, looking at some more long-term endpoints. HiPitho is a catheter lysis study that's ongoing right now. There's the study from Denmark, the Stratify study, a 3-arm study looking at catheter lysis, systemic thrombolysis, anticoagulation alone. I think these large studies comparing technology, the new technologies like mechanical thrombectomy with anticoagulation are really important studies. Got to be careful with them, right? I mean, we have individuals out there say, I'm just going to treat this patient. I can't randomize this patient. He needs to be mechanically thrombectomized. And so we worry these studies aren't going to be done well enough if we don't have equipoise. We need to have equipoise and get these studies done, Geoff. But they're coming. And I think we've got studies in high-risk PE now. The Persevere study, 200 patients randomized to either catheter mechanical thrombectomy versus whatever the standard might be in that hospital. Systemic thrombolysis will often be the standard. So these studies are going to help us. And in DVT, we've got the Defiance coming, anticoagulation versus catheter thrombectomy. So I think the next couple of years, Geoff, are going to be really incredible in terms of more and more data.
Well, and it's so important because it feels like these devices have matured to the point where we know how to use them. The question now becomes, which patients need which sort of intervention and what outcome are we going to see benefit? And I think that sort of lineup of trials that you outlined, many of them compared to anticoagulation, are going to hopefully help us answer those questions so that we can offer better care for patients. Is that sort of how you're seeing this landscape over the next several years?
Geoff, I think you stated it very well there. And I think another thing that's really going to help us here is the PERT consortium, the PERT concept. And the PERT concept is not the same at every hospital. At some hospitals, it's 1 or 2 different specialties. At some, it's more. But I think the multi-specialty approach to this disease is going to make a big difference here. And I think your work and others in the PERT consortium are going to make a big difference here.
Well, I always love hearing these conversations from experts like you all, but I also love reminding everyone in our community that, you know, we really are a group of interesting and dedicated individuals. And part of that is sharing a little bit about ourselves, maybe outside of work, things that others don't know, a fun fact. Andy, maybe I'll start with you. What's a fun fact that maybe others in the thrombosis world don't know about you that you'd be willing to share?
Well, I would say my fun fact is my love for my college football team, Ohio State, but unfortunately, most people know that about me. So I would, one thing that's not mostly known, I would say is I have quite the obsession with Dave Matthews Band. I have been to 51 concerts now for Dave Matthews Band. So that is another one of my big passions in life. So,
well, for our global audience, I'm sure most of them have heard of Dave Matthews Band. For everyone else, that football you referred to, that's American football with the oddly shaped thing, not soccer as we would call it here in the US, right?
Right.
Vic, how about for you? What's an interesting fact folks may not know about you?
Oh, wow. I'm not sure there's really anything, Geoff. I pretty much work a lot, and that's it. But thank you. No, well, let me try. I can tell you for decades, I did martial arts. That was kind of my fun thing. I kind of ventilated, sublimated. Martial arts were a lot of fun for me. I've learned more recently that playing guitar is much easier on my body. And so I've gone that route a bit more. I enjoy music. I enjoy concerts. I just saw Gregory Alan Isaacoff at the Santa Barbara Bowl recently. Oh, wow. Great singer, wonderful singer. I highly suggest him. I haven't been to quite as many concerts as Andy. I got a little ways to catch up, but I love music too.
We'll keep working at it, and you may catch up to him one day. I like that.
Yeah.
Well, thank you both for joining us today. This was just such a wonderful conversation. I love learning more about mechanical thrombectomy and where it fits into our current armamentarium for treating patients with venous thromboembolism, and certainly all the ongoing studies. I think that's really going to be helpful. I want to thank Inari, of course, now part of the Stryker Corporation, for the generous support in making today's episode possible. And if folks want to learn more, you can visit www.inarimedical, that's Inari with an I, inarimedical.com. Vic, Andy, thank you guys for joining us. This has been a wonderful conversation.
Thank you, Geoff.
Thank you so much, Geoff.
Keep your great work going in the field, Geoff.
I appreciate it.
Can't thank you enough.
Take care, guys.
For all our listeners, thank you guys, and we'll look forward to seeing you on the next episode of ISTH's The Pulse Podcast.